inbox. And using the new name in 2023, you should see this new sort of color scheme on our monthly newsletters, and we're tying it into the other communications that we share. As Robin shared earlier, this was part of a multi-year strategic planning process. We began discussing it in 2019, put it on pause in 2020. But some of you may remember that we asked all of our members what they think about a name. And so this name was one of many that were proposed, and it was the one that you all basically told us made sense and really aligned with what we're working to do. And that's facilitating collaboration among organizations that focus on healthy lifestyle behaviors.
Got it.
Yeah, just noticed that. Thank you. Our colors represent those of our home institutions. So for those of you who don't know, obviously we said Children's Mercy. The blue and the yellow are a nod to Children's Mercy. Our academic affiliation is University of Missouri, Kansas City. And where the Kansas City Healthy Lifestyles Collaborative sits is within the Center for Children's Healthy Lifestyles and Nutrition, which is a joint center between Children's Mercy and the University of Kansas Medical Center. So we've got yellow and gold that are a nod to Children's Mercy and UMKC, and white, the blue and white, which is a nod to KUMC. Oh my gosh, when they have all the same letters. We had a few icons that people also voted on. We settled on a heart, which we think is also a subtle nod to the KC heart you see all over town, whether it's on the Kansas City Monarchs, the city of Kansas City, Missouri logo, and countless t-shirts around town that have the heart on it. And Kansas City is the heart of America. So thanks to everyone who participated in helping us create this new logo. We hope you think it aligns with what we're doing as much as we do, and we want to use this to connect our work across the variety of initiatives that we're doing. So you may see this represented slightly differently in different places. This is our stacked center logo. We also have a horizontal one. You might see us just pull off the icon, but it's all the same work. Okay, so with that, I think we'll go ahead and get started with sector updates. So I'm just, I can't remember what order I put them in, so I'm going to put you all on the spot for those of you who are giving these updates. And you're welcome to come up here so that our online friends can hear us.
Great. Yeah, I'm happy to give the updates for so these next few updates will be for the Kansas City Physical Activity Plan. So just as a reminder, we have several initiatives going on. Kansas City Physical Activity Plan is probably our largest that is active right now. And so we have 10 active sectors. So we're going to give updates on 6 of them or so today. So I'll give a few. The first one is sport, and our leads, our community co-leads for the sports sector are Bill Brandmeier and Adrian Roberson. Bill is with ShareWaves, which is a nonprofit arm of 810 WHB. And Adrian Roberson, he's the director of youth sports and education program over in Wyandotte County called KC United. So there are 2 leads. We've been working behind the scenes for probably a good 8 months for our biggest implementation project, which is a partnership with the Aspen Institute to be their next Project Play community. This is a really big deal. The Aspen Institute is a think tank out of Colorado. They do a lot of different things, some political things. They have a big sports and Sports in America, I think, arm of the Aspen Institute. And they have done, I think there have only been 12 community partnerships that they've ever done. So I think we're going to be the 13th, and we're the only one that has ever been done in the Midwest. So this is a really big deal to establish this partnership with them. We are doing the pre-work right now. and the actual work will begin in August. So you may hear some things over the next, 3 or 4 months, and then things will really kick off in August. And what this will be is they will work with us and our partners, all of those, any entity that might be involved in youth sports. So I'm looking at our Parks and Rec partners. I'm looking at some of our sports-based providers, all of our pro sports teams, anything that has to do with youth sports. We're going to get them involved in the process. We'll do a very large data collection process. Then they will, about a year from now, they are going to host a very big all-day summit where we're going to bring in everyone in the region who's involved with youth sports. This is going to be a large 100+ person event where they're going to share the initial results, get feedback from those stakeholders, and then ultimately they'll release their project play report for Kansas City. And you can just Google Aspen Institute Project Play, and you'll find the other previous reports they've done. It's very, very thorough, and it's going to be a big catalyst for creating safe and equitable opportunities for all kids to be active in the sports setting in our region. So we're beyond excited about that. If you want to know more, you can attend our monthly meetings. I'm going to look, I think our monthly meetings are always the second Wednesday of the month at noon. So the next second Wednesday is next Wednesday, March 8th at noon. So you can sign up. Shelly's going to go through how to sign up for all of our meetings in the next couple slides. So any questions about that? If you do have some, grab me afterwards. Schools next.
Great. So we have Christine Scherenberg here with us today, who's one of the sector co-leads for the school sector. As I think you heard her say, she's from USD 500 and a lead P instructor for that district. Robin Stewie is the other lead for this sector, and Robin is with the Midwest area and supports Fuel Up to Play 60. This group meets on a monthly basis. Our next meeting is March 23rd. We just recently had a meeting a week. Was it last week? Is that right? Yeah. And so this group is actually working on some implementation projects and Bike Month. There is a group from the Johnson County Health Department, or Department of Health and Environment, and Mid-America Regional Council working together to promote resources, to put together resources and promote May as Bike Month. So look for more information coming out from this group about that. We'd like for you all to get involved and help us spread the word next month, in particular, in preparation for the activities going on in May. Early childhood.
Good morning, everybody. I'm Rhonda Opelman.
We have two co-leads for that group, one of them being Lori Lanter there at the back, and she mentioned she's with the Unified Government of Wyandotte County. Our second one is Rhonda Erpelding, and she's with Harvesters, and I think she's on our virtual portion of the meeting today. That group meets on the fourth Thursday of the month at 9 a.m. If you want to get involved with that group, you can email me. We also have two implementation groups that are also meeting monthly with that group. One is focused around resources. So they're at the point where they're kind of reviewing the large scope of resources that there are that are for promoting physical activity in early childhood settings. One is going to be targeting the providers and actual center-based resources, and another is for families to continue that work at home. The second implementation group we have is that Go Knapsack Review group. We recently got a report from them, and that report shares information across 7 health behaviors targeted in early childhood centers. Examples being physical activity, of course, nutrition, oral health, breastfeeding, etc. Based on that, we can kind of see the gaps that we have in the Kansas City metro area. And then they'll design implementation projects based on that report and their review. Okay.
Thank you, Natalie. Anything else you'd like to add to that, Lori?
Maybe just that we did discuss and had made that recommendation for that funds to be dispersed.
Oh, yes. Okay. So for those of you online, Lori also mentioned we've recently received an application for funding that we have available to support an implementation project through Start at Zero. So we're excited to be able to actually move that forward with a more formal project. Parks and Recreation. Katie's going to come up and give that update.
So Parks and Recreation meets the third Wednesday of every month at noon. Our next meeting is March 22nd. I said noon, it's 1 o'clock. Yes, and our co-leads, we actually have one here today, Allison Smith, with Johnson County Parks and Recreation, and then Jen Jute, I'm not sure if they are online, but they're with the Kansas City, Missouri Parks and Recreation. And right now, we're really just focused on trying to figure out our implementation project that aligns with our sector strategies.
Yeah, great.
Okay.
Perfect.
I think the next one is public health.
Oh,
So
okay.
I'm just going to stay up here.
Allison, do you have anything to add to that Park and Recreation update?
We've got a couple applications that are coming in this month. And they're with outdoor activities in parks like fishing and some bike programs and golf.
Okay.
So those applications are coming in. I've talked with those different individuals who will be applying.
So for those of you online, Allison is sharing that there are a couple of implementation project ideas that are coming to that sector to move forward for potential funding, and they involve outdoor activities like fishing and other such things. So we look forward to hearing more about that.
Shall I just say we'll give an update on the implementation projects in a couple slides, right?
Yes.
Okay.
Yes,
Okay.
thanks, Robin. For those of you who aren't aware of when we talk about implementation projects, what that is, I do have a slide to give you a little bit more background about our process and how we're accepting applications. So it looks like healthcare is next. I will give the healthcare update. So our healthcare sector lead is Jody Dickmeyer, a pediatrician at Children's Mercy. She is in clinic this morning, and so I'm going to share that update. The next healthcare sector meeting, as you can see, is March 21st. It's generally over the noon hour for about 45 minutes. The healthcare sector has 3 implementation groups that are actually working on projects. I'm going to share information about 2 of them today. One of them is Just Walk. Just Walk is a program underneath Walk with the Doc. How many of you are familiar with Walk with the Doc? Most of you. Okay, that's great. Some of you are not. So Walk with the Doc is a program that started in 2005 by a cardiologist who noticed he was telling his patients to be active, but they were having difficulty actually being active. So he decided to walk with them. And that led to where we are today. Walk with the Doc is an international program, and they've expanded to just walking with physicians to walking with any healthcare professional. That's why we use the term Just Walk. Our walks are led by a variety of healthcare professionals. Our walks take place on the first Saturday of the month and in Pearson Park in Kansas City, Kansas. So our next one will be April 1st. This QR code that you see on screen, if you scan that, it will take you to a form that will give us your email address where we can send more information about the walk if the walk changes for whatever reason, if weather impacts our ability to get outside and walk. But we're really excited to partner with Wyandotte County Parks and Rec and host this there. We are also working on a second site in Kansas City, Missouri. I don't have any additional information about that at this time. We are also trying to partner with the other Walk with the Doc events that are taking place in the area. There's another one led by KU Med, another group from UMKC that leads these so that we can promote them all and share the variety of walks that are taking place across the metro for anyone who happens to be interested. We also want to make sure we're making it convenient for as many people as possible, and we're not interfering with the other walks that happen to be taking place. Another implementation group of the healthcare sector is related to curriculum. And so I included the strategy up here for those of you who aren't really sure what that might mean. So in the healthcare strategies, one of them is that universities and other academic institutions should include basic physical activity education in the training of all healthcare professionals. So we now have a group that recently started meeting monthly. It involves all 3 local medical schools, so KCU, UMKC, and KUMC. And we are also trying to expand that, and I say this because Joan's in the room and we just had this conversation this week, to other universities as well. So OTPT, dietitians, nursing, public health professionals, et cetera. So we want to include lifestyle medicine in the education of a variety of healthcare professionals. We meet monthly. We've only had our 2nd meeting so far. Our goal is to bring Dr. Jennifer Trilk from the University of South Carolina to Kansas City this fall. She has set up a lifestyle medicine education curriculum that's available for medical schools. She teaches this work at the University of South Carolina's medical school, is an international expert in this, and we're really excited at this opportunity. So again, in a few minutes, I'll show you, if you're interested in any of this, how you can sign up to participate. Okay, now it's public health. I'll bring Katie back up.
Okay, so our public health sector is actually led by Joey Leitner. He's an associate professor at UMKC. We actually just started the public health sector in December of last year. And so we're still getting things up and running. We meet the 2nd Thursday of every month at noon. And right now we're just focused on strategy prioritization based off of currently what's in the National Physical Activity Plan. Yeah.
Great. Okay. Yeah. Okay. Next is mass media.
So I'll give the update for mass media. We have 2 community co-leads for the mass media sector. One is Toriano Porter. He's on the editorial board of the KC Star. And the second is Melinda Shahane, who's does marketing at UMB Bank. So there are 2 co-leads. We are very excited because we received some funding and we were able to form an official partnership with Overflow Company, which is a media PR firm, and they are going to work with us to develop a brand and messaging guide around both the Kansas City Physical Activity Plan in general, and we can tailor it specifically to the needs of the individual sectors. So for example, you know, we heard about Just Walk. How can we communicate better out to the public what the Just Walk program is and how to get people involved? So we're now in the long contract review stage with Overflow. So our meetings are kind of on pause at the moment. We normally meet at the last Tuesday of each month, but we're just kind of waiting for the contract to get approved before we start that project up again. But when we do, again, you've heard this a lot, we'll be reaching out to our partners in the other sectors to get their input on what this messaging campaign and PR strategy should look like. So this is going to be important because we can have really, really good programs, but if we can't effectively communicate them out to the public and disseminate that information out to the public, we're really just talking to the people in this room. So we're very excited for that. Keep your eyes open to your email inbox for more information on that. And I'll just say, I guess you'll maybe get this. So there's a couple others that are kind of in transition phase right now. I'll just talk about the infrastructure sector. We were really active for the first couple of years. Then we had a change in some of our co-leads. We're bringing new co-leads online. So we hope to bring the infrastructure sector back online in the next few months. So I'll let Shelley talk about the others.
Right. So the other two sectors that are involved in our work is business and industry and faith-based settings. Faith-based settings has already gone through the strategy prioritization process, sort of like infrastructure, but took a brief pause with COVID. As you can imagine, they were really focused on making sure they were addressing the needs of their congregations. And then in the last year or so, working to get people back in person in churches. And so that group has taken a bit of a pause. We're trying to bring that group back together and figure out how does what's going on in the other sectors align with what's happening in faith-based settings and connect our work together. Business and industry has not yet started. We've had some transitions with potential leads. So if anyone here is interested in being a lead for the business and industry sector, we are looking for one and hope to get that sector started as soon as we can identify leads. Business and industry is primarily focused around employee wellness. In case you weren't quite sure what that meant and how that connects to all the other sectors that we've identified for this. So with that, I'm going to pause for just a second and see if anyone either online or here has any questions about these updates that we're sharing. I will, in just a few minutes, show you all how to join the work. One option will be through the evaluation, and there'll be a QR code at the very end that will have our evaluation linked to it. You can sign up to be a part of a sector through that. I'll also show you where you can find information on our website in case all else fails and you didn't get something done when you'd hoped. There's always an easy way to get involved. But any questions? Dr. Kramer.
A couple of sectors mentioned that they think of Mike Walk KC, which I think are involved.
Yes, great question. So Dr. Kramer is saying there are a couple of sectors that he thinks make sense for Bike Walk KC to be involved. Yes, they are actively involved. In fact, they are probably going to be one of the co-leads for the infrastructure group. Yes. And we meet with a variety of staff from Bike Walk KC on a regular basis, but you're right.
And at schools also, they're very tuned into bike to school day and everything else to do with schools.
Yes.
Bike rodeo.
Well, in fact, so Dr. Kramer is mentioning Bike Month and Bike Walk KC's involvement with Bike Month. In the past, a staff person from Bike Walk KC was actually part of that group and helping to share information. I believe that person has moved on. Yeah. And so we're waiting for them to identify who else can participate in the school sector to help us move some of these pieces forward. I think the group, so Jill Rayford and Patrick Truba are the ones who are coordinating Bike Month resources. And I believe they have reached out to Bike Walk KC to bring them back in and make sure that we're promoting programs and activities they have going on for the month as well. But thank you for bringing that up. Yes, very important. Any other questions about the sectors or the work that's going on? Okay, so now we'll give you a little bit more background on implementation projects. So I've mentioned implementation groups. What that just means is these are groups that have set up that align with the strategies that have been identified from the different sectors. The implementation projects are around funding that is available for the different sectors. And I'm going to let Robin come up and share a little bit about the implementation projects.
And just to follow up on the bike walk comment, a young man named Carl Kramer was our liaison, and he was excellent. We loved working with him, and he has moved on to bigger and better things. So if you happen to see him, give him our best.
Maybe having lunch with them today.
Oh, okay, great. So implementation projects. So we were very clear when we started the Kansas City Physical Activity Plan. We did not want to create a plan that sits on a shelf. There's a lot of those out there. We wanted to be different. So we put a lot of effort into actually implementing the 50-some strategies and 150 tactics that we have developed over the past 3 years. So we are very fortunate that we received some funding from the Kemper Foundation to support these implementation projects. And so we are now allowed, or we have funding to give away at a minimum $10,500 to each sector to give out to community partners to implement strategies and tactics that align with the Kansas City Physical Activity Plan. We anticipate that there will be actually slightly more than that available in total for each sector, but at a minimum, $10,500 per sector that will go out to not Children's Mercy, to other community groups to do this work. So these projects have to be aligned with strategies and tactics within the sector. And so if you are active in your sector, you've been attending the meetings, you've heard a lot about this. If you haven't been, but you think, oh, wait a minute, my program might be interested in receiving some fundings to do a project, the best way to do it is to go to the sector meeting and talk to, there's always time within that meeting to talk to the sector leads and other sector members to figure out what they have maybe funded in the past, and they can tell you how to find the strategies and tactics that they've already approved. And then you can just give, you can fill out a very short one-page application. It's like 5 questions. That is reviewed first at the sector level, and then all this other sector members can ask questions about it and make sure that it truly aligns with what is happening within the sector. And then it gets pushed up to what we call the core work group, which is all of the sector leads get together once a month and we sit around and we talk about what these implementations have been proposed. So we'll review that at the core work group level and hopefully fund your project. So it's a great way to do work that is aligned with the Kansas City Physical Activity Plan on our dime, or really Kemper Foundation's dime. So as you've heard, several projects have already been funded. We're reviewing several more in a couple weeks when the core work group meets. So any questions about that? For example, the mass media PR strategy, that comes from an implementation project. The Aspen Institute, that is being funded through some implementation funds. So Just Walk, expansion of Just Walk is funded through an implementation projects. Any questions there? Okay.
Okay, and anything online that you're seeing, Natalie? Okay, so now I'm going to see if this works. Let's see. I may need to put my glasses on to be able to do this, but I want to show you our website and navigating the website just a little bit so that you know where to find things in case they need to disappear from your inbox. And this ought to be challenging. Let me see if I can move this around so I can navigate. Okay. The first thing I want to make sure to point out is that we have a website and you can find all the things KC Physical Activity Plan related there. So the actual plan is available right here on this link. For those of you who aren't familiar with it or haven't seen it, it's a nicely dense plan that includes a little background, strategies, tactics for the different sectors. This is the first version of our plan. We are currently updating our plan and plan to have that released by the end of this month. We will probably send that out as an email communication, but we'll automatically update this link as soon as that's available. You can also find additional information here. I'm just going to hover over this. As a reminder, we model our work after the National Physical Activity Plan, so you can access the national plan here. We also link it to the US report card. We have done a local or a Kansas City physical activity report card, also modeled after national work. We have more information about summits that we've hosted, strategies, tactics, and this is what I really want to point out. For those of you who aren't aware, each sector sends out newsletters. Let me take that back. Not actually each sector, but the sectors that are meeting on a regular basis send out newsletters at the follow-up as follow-up to the meetings that they host. That will come to your inbox. If you don't want to save it there, you don't have to. All you have to do is come here online, click on a sector, and it will take you to the newsletter links right here on this website. So if you missed something, if you want to see the meeting recording or the notes from the last meeting, you can just go right onto this page of our website and access that information. The other thing we talked about is joining meetings or trying to figure out, oh my gosh, you guys threw all these meeting dates at me. How in the world am I going to remember that? Well, the good news is you don't have to. Go onto the website. Under Join Us, you can click on upcoming meetings. We have a calendar. You can see this is March. So you can see today we have our Healthy Lifestyles Collaborative meeting. Next week is sport. Then the following week is public health. And then the last week of the month is quite a few different sector meetings. Those will be here. You can scroll down to the list if you want to register. As you click on that link to register, you'll also find the Zoom link. So this is very helpful if you're trying to attend a meeting and you can't remember where the Zoom link is, or you're confused by how the meeting invitation is showing up in your calendar. You can go here, click through the registration link. The Zoom link is right there on the site. You should be able to click through it and access the meeting. Okay. Anything else about the website that you have questions about? We are updating it regularly. We will be adding a resource section to the website soon. We're actually compiling the resources and trying to add them all at one time, but that's in the works. It will tie back to a project you heard us mention earlier related to early childhood, but every sector will have resources available on it. If you know of resources you think we should include, please feel free to send them to us. You can email them to any of us directly, or you can email them to our new email address, which is kchlc@cmh.edu. Okay. Any questions online that you're seeing, Natalie? Okay. Last couple of updates. I'm going to skip this since we just sort of talked about that. Last couple of updates. For those of you who aren't aware, Children's Mercy has a community garden. We started the community garden in 2018. It is currently in bed. The garden is asleep. We are going to open it on March 28th of this year. We have been working hard to partner with outside organizations to distribute produce. Pre-COVID, we were able to give quite a bit to the families, patients and families at Children's Mercy. Post-COVID, it's a little bit harder to do. So we've been partnering with Canby's Market to package and distribute our produce to families through a home delivery pilot project we've been doing in Kansas City, Kansas. And then we also are the fresh source of produce for the UMKC student food pantry. So during the season, we have students who come over, pick up the produce that our volunteers harvest and take it there for distribution. We do have a garden newsletter where we share information, and we are a completely volunteer-run garden. If anyone is interested in volunteering, email us at communitygarden@cmh.edu. Or if you have great ideas for us to pilot there, let us know. We do have a Girls on the Run team that meets in the community garden. They learn a little bit about gardening at each of their practices. And they've helped us do a couple of community impact projects through the garden as well. Okay, now it's time for you guys to give updates. Is there any project, program, information that you would like to share that you have going on through your organizations? And online, they're welcome to share anything online, and we can share it with the group here as well.
This is Teresa Tunstall from Clay County Public Health Center. I
Donna.
just wanted to share.
You probably have a really great update, so I want you to come and share this with everybody online. I'm hoping it's about Double Up Food Bucks.
Well, yes, of course.
Awesome, putting you on the spot.
Yes, of course. It's about Double Up Food Bucks. So it's 2023, beginning of the year. So that means we're ramping up for a new farmers market season. The grocery stores are still doing the program, but we try to really focus a lot of attention when it's farmers, when the majority of our farmers markets are open. So we are right now in the process of updating our brochure. So I'm just putting it out there. If you are one of those places that are so awesome that you are helping us get the word out through our brochure by distributing our brochures to people that you might be working with in your programs. We hope to have those maybe late March, April timeframe. Long story short, if you would just let me know if you are interested in getting a chunk of those brochures. I know we will have English and Spanish, definitely. So we're happy to get those to you as soon as they start rolling in. Yeah, please help us get the word out, because that's our biggest challenge, is like people still don't know about this program, which is almost a crime. And a really exciting news is we actually have 2 more grocery stores coming on board, the KC Sunfresh stores that are, one I think is on Blue Parkway and the other is Linwood and that area. Yeah, so both of those stores will be coming on this year too. So it just continues to grow. So we appreciate all of your support. Thanks.
We will plan to include that information in our upcoming newsletter. If we get it, we can include it this month if you'd like, and we can include it in April's as well. So for those of you who want resources, if you're online, just drop it in the chat. We'll make sure we help coordinate getting you connected with Donna and getting you those resources. Okay, so they've asked to be unmuted. Okay, you are now unmuted.
Teresa, I think you had a comment. Sorry that we cut you off there.
Hi, that's fine. This is Teresa Tunstall from Clay County Public Health Center. We are having our 8th annual Family Fun Day. We just set the date for this year. It will be on Saturday, September the 16th from 10 a.m. till 2 p.m. at Mackin Park in North Kansas City. Last year was the first year we did it in that site at Mackin Park, our first in-person one since the last 2 years with COVID. We did it virtually. We had between 35 and 40 vendors with the focus area of physical activity and healthy nutrition. And we had over 800 people that came through our different areas. So we're looking forward to a great year again this year.
Thank you. That's amazing. Dr. Kramer?
I just thought of one other event, UMKC. This is the 2nd annual Kansas City Community Health Fair. In June, and then
June 10th, I think.
that sounds right.
Yeah.
Yeah, I know. Everybody's probably been there on that happening. One of the leaders on that from the faculty standpoint, and it's underway. So mostly student organized, and we just kind of try to keep them on track.
Dr. Kramer is sharing about a student-led health fair that will be happening in Kansas City, Missouri on June 10th. It is, I believe, open to the public. It's free of charge, and they're doing quite a few health screenings and demonstrations. We will also communicate that in our monthly newsletter, so you all can share that with partners or participants as well.
And the location is the Kansas City Health Department.
Oh, great. And the location is the Kansas City Health Department. Okay, perfect. Great. Any other updates? Oh, yeah, Alex.
So the Kansas City Spirit Playbook is the comprehensive plan for the city. It's only updated once every 25 years and it's open for public comment right now. And there are plenty of places where you could intervene to try to advocate for more built environment specific spaces for physical activity. Public health section honestly might not be the best one. My team and I did write that section, but there are other places that might be more conducive to that feedback. So I just wanted to put that open. I'm not sure when the review period ends, but I do know that it is open as of today. So just keep that in mind if you have any advocacy about that.
So the Kansas City Spirit Playbook is open for comment. We will, if you'll share information with us, we're happy to distribute that to our newsletter. It's available for public comment, it sounds like. Yeah, and we're not quite sure the end date, but we'll get that all out to you. And Alex is mentioning the public health sector may not be the best or the only sector to provide feedback in. Yeah, so please take a look at that and provide any information or feedback to that group. It is a big deal and it does guide the work that's going on in the area. Okay. So to keep us on track, we are an organization that fully believes in role modeling. And so we don't want to have a meeting without having an opportunity for a physical activity break. I have no idea if this is going to work or not. It is a recorded break that was led by a staff person at Children's Mercy in our Employee Fitness Center. She's fantastic. So we're going to see if we can make this work.
We're going to start with some neck stretches. So just place one hand on
So I encourage you all to stand up. You're online, stand up.
straight down, trying to reach those fingertips all the way towards the ground. Good. We're going to switch. Do the same thing on the other side. Try and relax your neck as much as possible. Reach those fingertips down. And then we're going to take both hands behind the head, elbows forward, pull down and round in the neck. You can kind of rock your head side to side here if that feels good to you. And then we're going to go into some shoulder rolls. So just a few to the back, and a few to the front. And then we'll cross one arm over and pull, and we're going to add a torso rotation here. So just rotating to the side. Should feel this all throughout that shoulder. And we'll switch sides, same thing on the other side. Rotate the other way. Good, and we're gonna go into our lat stretch. So bend at the waist, reach over. Should feel this stretch all the way through the side of your body. And switch sides. Same thing on the other side. If you need some extra help or pressure, you can grab that wrist and pull for a little bit of extra on this stretch. Good, and we'll switch to our lower body. So we're going to start with the quad stretch. If you're still seated, you'll need to scoot to the end of your chair, turn to the side. Hopefully you're standing with me. And then really push those hips forward. Should feel this all throughout the front of your leg. And then we're going to take that foot that we have hold of, sweep the leg through, heel down, toes up. Reach down to the toes. The opposite hand can just be supported on your knee. And if you can, pull back on those toes, so we'll feel a little bit more calf. And come up, good. We're going to say the same thing on the other side. Quad stretch first. Pull that heel in, push the hips forward. Run all the way from your hip joint, all the way down to your knee joint. And then spin that leg through, heel down, toes up. Reach down for those toes. And come on up. Last lower body stretch we're gonna do is our glute stretch. So cross that leg over. Squat down, push the knee down, hold on to something if you need to. Apply pressure on the knee, flex that foot. And if you need more of a stretch, go ahead and move your chest a little bit closer to your leg. Good, switch to the other side. Same thing. Cross the leg over, flex the foot, push the knee down. Relax that glute as much as possible. And move your chest closer to your knee if you need to. Good. All right, last thing, interlace those fingers. Round in the back, rock side to side. Couple high, couple low. And whenever you're ready, reach all the way up. Big deep breath in. Exhale, reach down for those toes. Or you can grab your elbows here and rock side to side. Release the lower back a little bit. And then let's pedal our legs a couple times. So bend one knee, straighten the other. And switch. One more time. And roll back up nice and slow whenever you're ready. That's all I got for you guys.
Okay, I hope that got your blood pumping again.
Today we're here on legacy.
Here we go, this ought to be fun. Okay. We are going to take a 5-minute break. We want to upload our presenters presentation. And it's going to take us just a couple of minutes to get that done. So if you need to use the restroom, it's all the way down the hallway on the right. For those of you online, we're just going to mute ourselves for just a minute in preparation for Dr. Hantel's presentation. We'll be back in, let's say, 3 minutes. What's that?
Screen looks a lot like this line right now.
Yeah, I'm not sure with that. That's just on that one. Okay. All right, well, I'm gonna bring the group back together. And Evelyn, please let me know. I think most of the group is probably back together online. I'm gonna go ahead and keep us moving because we have an outstanding presenter today, and I want to make sure she has plenty of time to share this updated information with us. So I have the pleasure of introducing Dr. Sarah Hampel, who is the lead author for the new clinical practice guidelines on the evaluation and treatment of children and adolescents with obesity. So Dr. Hampel is board certified in pediatrics and obesity medicine. She's a professor of pediatrics at the University of Missouri, Kansas City School of Medicine. That's a mouthful. She's a member of the Center for Children's Healthy Lifestyles and Nutrition at Children's Mercy, Kansas City, and directs advocacy initiatives there. So we have the pleasure of working with her on a regular basis. She's been working with children and families with obesity for the past 25 years. She provides clinical care in the Fit Kids Weight Management Clinic, which is promoting health in teens and kids. And she's the medical director of weight management group programs. She is a founding member of the Kansas City Healthy Lifestyles Collaborative in its original version as weighing in. And we are really excited to have her here to share the background and updated guidelines from the AAP. So without further ado, Dr. Hampel.
Well, thanks a lot for asking me to speak, and I really value my experience that I've had with weighing in and now the KC Healthy Lifestyles Initiative, and hope to get through these slides, and we'll try to kind of break down some of the more technical information for you. So I wanted to start by taking a look back at previous sets of recommendations. And even back in 1998, there was the first set of expert committee recommendations that were really co-authored by two individuals with input from others. And the way that happened was that there was just a 2-day meeting versus now the current guidelines took nearly 4 years to put together. And it was a 2-day meeting, and 20 institutions or organizations were represented. And one individual who's wonderful, Dr. Sarah Barlow, wrote the manuscript and got input and sign off. And at that time, there was an algorithm that was presented for the evaluation and treatment of children with obesity. And they acknowledged freely the lack of evidence that was available at that time. And so the recommendations were just that. They were a group of experts that convened and gave recommendations. So things have changed quite a bit. And then back in 2006, the circle expanded a little bit more widely in that a little bit more breadth of organizations were involved, and the CDC got involved, and the American Medical Association and the government, and convened a series of meetings. Nonetheless, it was a huge task, and they were still termed recommendations. That each of the groups, each of the 3 areas of the recommendations had an authoring group, and that group was tasked with a literature review of the literature that existed at that time to develop their recommendations. And so there were three sets. A summary is the top one, and then 3 different groups: assessment, prevention of obesity, and then treatment. So where are we today? We know that the number of kids with obesity has continued to rise. So now nationally, we're looking at over 14 million kids and teens are affected by obesity. And we know that obesity affects immediate and long-term health of children. And that they are susceptible to many diseases that are highly associated with obesity, such as type 2 diabetes, hypertension, sleep apnea, fatty liver disease, and depression. And that's not all of them, certainly. So the American Academy of Pediatrics and the CDC have been concerned about the rising rates of obesity and the fact that we had not had a formal set of recommendations since 2007. And so in 2017, the CDC sponsored an evidence review and the writing of a couple of technical reports that would help get the process started. And then the AAP had developed a system of developing clinical practice guidelines for a number of different pediatric health topics, and they applied to have this particular topic approved, and they were approved to write a CPG. And so when I came on was about in somewhere in 2018, being asked to chair the writing group, but our writing group had a gift, and that gift was that the evidence review and the technical reports were already largely written by the time we started our work in 2019. So that way we didn't have to do the evidence review ourselves. It had already been done by a separate group of authors, some of which crossed over and were also on the writing group. So that added a really nice perspective for our writing group. So that's kind of the genesis of how we got to where we are today. And of course, you know, in the middle of this was the pandemic. So we had our first face-to-face meeting as a writing group 1 month before the pandemic started. So it was very heroic, I think, for the writing group to have come up with this comprehensive set of guidelines in the midst of all the other things that they were pressured with, and that many of us were all pressured with. So my hat's off to the other 19 members of the writing committee. So in a, you know, kind of by the numbers, it had been 15 years since the last guidance. That evidence review group did just a gargantuan job. They reviewed 16,000 abstracts and narrowed it down to about 1,600 full text articles that represented 382 studies, and then wrote the technical reports that we based the clinical practice guideline on. And that guideline has 11 consensus recommendations and 13 key action statements. Again, according to a process that is really founded on Institute of Medicine, now National Academy of Medicine principles about evidence review. And then the AAP had a whole manual about how to write a clinical practice guideline that we used in order to create the CPG. And we used an evidence grading system, again, based on IOM guidance that had been previously given about how to grade the evidence. So the evidence was already kind of divided for us and classified for us when we got it. But in order to write the key action statements, which were the main recommendations for the document, we had to look at how strongly were we going to make the statement versus was there a little bit more ambiguity and we needed to not be quite as strong in our recommendation. So there are different levels of the recommendation according to these this guidance. So the main areas of the clinical practice guideline are assessment and evaluation of kids with obesity. What is the assessment of the comorbidities or the complicating factors that we know can go along with carrying extra weight? And then what are the evidence-based treatment options? This clinical practice guideline does not cover obesity prevention. And I know obesity prevention is near and dear to many of our hearts, but the guideline was specifically directed toward treatment. There is going to be additional guidance, and there already has been in the past 10 years, at least from the AAP, about prevention of obesity. And there's going to be a new position statement that is going to be coming out in the next year about obesity prevention. And I should also say that the AAP, their primary audience is primary care providers that take care of kids. And so it is whatever the prevention statement will be is going to be primarily directed in a clinical way. Definitely, I know they're going to be talking about clinical community connections that we're all interested in, but primarily that document is going to be a clinical document. And what can the primary care provider do in their office as they're seeing kids, young kids, especially for well child visits, and how can they help families maintain healthy weight or improve likelihood of healthy weight in their children. So the kind of the main focus of the clinical practice guideline, or kind of the framework that we organized around, was the whole child. We know that obesity affects a child not just physically, but emotionally, and it affects the family, and kids live within an obesogenic environment. All those things we know here as this group. And we felt strongly that we needed to have a whole child care approach. So here's some just kind of new things from the 2007 recommendations, comparing now to then. First of all, there's been an explosion of research, and whether you're in the treatment space or the obesity prevention space, you know that the number of articles and the research in these areas has just exploded in the past 10 to 15 years. It's probably one of the highest the most growing areas in terms of research, whether it be community-based or clinical. And so along with that, we now more fully understand the implications of obesity as a chronic disease, one that tends to not always go away after 2 or 3 visits, but one that sometimes and often does follow kids into their adult years. We understand more about the body impacts, the medical impacts of the social determinants of health on obesity more completely. And we know more fully that weight bias and stigma is harmful. And it exists in many settings, school and clinical settings included, and even family settings. And that could be a barrier to treatment. Some other factors that are a little bit different from previous recommendations is there's really no benefit to watchful waiting. Most kids are not outgrowing their extra weight. The 2007 recommendations really included a staged approach, stage 1, 2, 3, 4, if any of you looked at those, and that was of increasing intensity. And they were good recommendations, definitely, and reflected the knowledge that was known at the time. But one thing that's different now is that we know more, again, about the chronicity of obesity and the fact that it does follow many youth into adulthood. So there's really no benefit to waiting and seeing if kids are going to grow out of their obesity, because most kids are not going to grow out of their obesity. It's also important because obesity is a main driver of many of the complications, the diabetes, hypertension, et cetera, that when you want to treat those complications, if you want to treat them effectively, you have to treat the obesity as well, because again, it's such an underlying factor for many of the complications. So there's no benefit to kind of waiting and treating obesity after the hypertension is treated, for instance, or the high blood pressure. It's important to treat both at once. There's multiple strategies that can be used collectively to deliver intensive and tailored obesity treatment, and that structured and supervised weight management interventions actually have been found to decrease current and future eating disorder symptoms. And I'll just say a little bit about this, because if you've watch the news at all, you know that this is an area that's gotten quite a bit of attention about the clinical practice guideline. And I want to assure you that that the members of the committee, which represent primary care providers, pediatric specialists, researchers, epidemiologists, a parent, a number of different stakeholders, we felt very strongly that we wanted to be cautionary about the fact that we know that kids with obesity have a higher risk of disordered eating, and therefore it's very important to monitor for disordered eating as kids are starting treatment and evaluation, and continue to monitor. So this is an area that has, because the clinical practice guideline is very long and kind of difficult for people to read through, people have in many cases not read the entire thing to know that there's a lot of emphasis placed on evaluation and reevaluation for disordered eating, and more needs to be done, in fact, but we can maybe talk about that at the end if anybody has any questions. So key takeaways from the guideline: it's a complex chronic disease. It's important to look at the whole child and be comprehensive about the evaluation, that treatment is safe and effective and evidence-based, and that when you treat obesity, you're also treating the comorbidities, and that treatment should be offered upon diagnosis. So just a little bit about the guideline, and part of what made it such a lengthy document is because we spent quite a bit of pages discussing what's known about the determinants of obesity from a variety of different influences. It's a complicated thing. You all know about the socioecological model, and it's even expanded even more. That, like, if you look at that individual center of that socioecological model, there's much more known now about the individual biological and physiologic determinants of carrying extra weight and maintaining extra weight, just as one example. And often it's an indicator of structural inequities, such as unjust food systems, environmental and community factors. And when you combine these obesogenic environmental factors with an individual's underlying predisposition to carrying extra weight, then they're, again, the interplay of those is very important to acknowledge. This is a nice kind of, and I probably should have put this a little bit later, but I just wanted to show that there are a couple of graphics within the guideline that kind of help explain and break down the information. But in general, the treatment approach is a coordinated chronic care model with shared decision-making, culturally competent care for the child and family with obesity, treatment coordinated in the medical home, as well as transition planning as these adolescents age into their adult years. How do we make sure that that their care is coordinated well? And that's much easier said than done. So that it's a partnership, again, between the patient and family and the medical home and community as well. And so when we look at, how can community organizations help with obesity treatment, I think there are a number of ways, and there are, definitely more ways that are being explored and that that will come in the future. But a strong emphasis again on this this bottom arrow, which is the structural and contextual factors that influence health and treatment. It used to be for people like me in primary care that it felt like maybe all we could offer was more common sense nutrition recommendations, and things have really changed since then. And it is we have a road ahead of us to really help equip those interacting with kids, especially in the healthcare space. What are those effective treatments? What are even effective primary care-based approaches to talking with kids and families about their weight? So I wanted to just talk a little bit about the evaluation. And again, because the primary audience for this is primary care providers, we really wanted to include what is known about how primary care clinicians can appropriately broach the topic, talk about it in a sensitive way, initiate evaluation and treatment, and coordinate care, and so forth. So this, again, the guideline is really devoted quite a bit to that discussion of the role of the primary care provider. So just, I won't go into detail, but we talk about BMI assessment. We talk about what consists of comprehensive evaluation consist of, and risk assessment as part of your history that you're taking with the family and monitoring over time. What are those different environmental and social risks that may be going on for them? And then how to do a full evaluation for obesity complications. So this is the statement about BMI. And we also have gotten a number of questions about, well, is BMI the only indicator? It certainly is not the only indicator of health. However, it is the best population-based measure that we have, BMI percentile, to look at kids' growth over time and to assess if there might be excess adiposity in a child. And now I won't go into this today, but there are now new extended BMI growth charts that you may have seen about that have come out from the National Center for Health Statistics that help us care for children with severe obesity. The traditional BMI curves don't really show how kids are doing who have severe obesity because their BMIs are too far above the 97th percentile. So these new curves are going to enable us to help track kids' progress better as one of their benefits. Risk assessment, again, we've kind of talked about already how important it is to be thorough with the risk assessment. And then evaluation really does set the stage for treatment, knowing that there are many things that may be right under the surface that we may not pick up unless we dig a little bit as clinicians for what else may be going on. So we recognize, just a word about race. We know that there is an association in some different racial and ethnic groups in terms of risk of comorbidities, for instance, or complications of obesity, and that this most likely indicates epigenetic, social, and environmental factors like social determinants of health, rather than an innate racial or ethnic predisposition. It's really more about the environment that that individual and family live in. In terms of the complications, again, the assessment really helps set the stage for what evaluation needs to be done. And just a general comment about evaluation is that, again, it needs to be not just the physical exam, but a full history, mental and behavioral health screening, a social determinants of health evaluation, and diagnostic studies. And not every single complication was addressed in this clinical practice guideline because we didn't have every single one covered in our evidence report. We had to cover the ones that were in the evidence report, but we also went a little bit beyond that because we felt it was important for clinicians. So the main ones that were discussed and had key action statements around them are the ones that you see here on the slide: hypertension, diabetes, prediabetes, fatty liver disease, dyslipidemia. But we also included a number of other ones that do occur and that are important for us to screen for and evaluate for, including some more rare conditions, a condition that involves high pressure within the CNS, depression, sleep apnea, polycystic ovary syndrome, orthopedic condition called slip capital femoral epiphysis, and then another orthopedic condition called Blount disease. And our lab evaluation main statement is that kids should be checked for these complications, especially the main ones. They should be checked. And even if they're not quite in the category of obesity, but maybe trending toward obesity, such as if they're in the overweight range, they should be assessed for these potential complications as well, which are very common. In our own clinic, we at least over 80% of kids that come in for an initial evaluation have at least one complication. Even at their initial visit. We also had to balance this with what was known about cost effectiveness of screening for some of these comorbidities. So it was a fairly complicated thing to get to the actual final set of recommendations and what there was evidence for. So the reason we're looking is for these complications is because there is strong evidence that obesity not only increases the risk for complications, but that weight loss can improve the complications. So it's important to consider that that simultaneous treatment approach. I included a few of these just to, because these were more of the overarching ones, but I'm going to skip over them just in the interest of time. We talk about some of the main ones and how to evaluate for them. Hypertension being one of the main ones. And then some of the less common ones that I showed on the screen, we did not make a formal action statement about those, but we did make consensus recommendations from the committee after review of the evidence and other societal guidelines. So let's get to the treatment part. I know that's what a lot of people are most interested in, and treatment should begin early as obesity is diagnosed and continue longitudinally through childhood, adolescence, and young adulthood with transition into adult care. And we put a strong emphasis on the medical home and the chronic care model, which if any of you are familiar with it, there is a special obesity chronic care model that was created by Dr. Bill Dietz and experts back in 2015 or 2016. And that was founded on the original chronic care model that was created in the 90s, I believe, that really puts the child and family in the center and looks at how we can best surround them with support. How can we also equip ourselves as primary care providers? How can we help engage communities, all the different communities that kids live in, to help in treatment as well. The most intensive longitudinal treatment should be what's applied, and the medical home is a good place to start. Anyway, it may in and of itself not be sufficient for management, but it's a good place to start. And because this guideline again is directed toward primary care providers, that was the focus, to initially ensure that the child is fully evaluated, again, not just physically, but emotionally and socially, and then developing an individualized comprehensive treatment plan using evidence-based strategies, treatment tailored as possible, and coordinating care, and even looking at what advocacy needs to happen for some of these treatments to, and this whole approach to be actualized in primary care. On the right is kind of the toolbox. What are the different treatment options that are available? And no, I mean, there is some order to it there, but there's no differential in terms of importance. We think all the treatment options are important, but there is a certain order by which you should go. And that would start with the approach to the child and family and taking more of a motivational interviewing approach, which is a patient-centered approach to helping patients and families change their eating and activity behaviors and a number of other factors that may be going on at home that can help support the child. And I'll speak about each of these in a little bit of detail. So motivational interviewing, again, is kind of the main approach to be used. And there are a number of different resources to help equip clinicians and anybody else that is interacting with kids. If they're interested in this type of approach, it's not just limited to clinicians. The foundation of treatment is considered to be intensive health, behavior, and lifestyle treatment. And there's strong evidence for this, especially in kids that are 6 and older. And I'll talk a little bit later about what does that consist of. The evidence is building for younger kids. It's not quite as strong yet for kids 2 to 5 for treatment, but it was definitely strong enough that we included it in the key action statement. And the dose matters, so that it's probably not going to be effective if it's 2 or 3 primary care provider visits. It's going to be more effective if it's more intensive. And the evidence supports at least 26 hours worth of contact time over a 3 to 12 month period. This is in line with the U.S. Preventive Services Task Force recommendations, but other evidence was also reviewed, because that evidence review was not the only piece of information, again, that was available at the time that the Evidence Review Committee looked at the information. So a child-focused, family-centered, coordinated approach to care, coordinated by the medical home, and may involve not just the medical home. It needs to involve individuals and experts outside the medical home as well. So what does IHBLT consist of? It's a mouthful, for one thing, but it was felt to be the term that really encapsulated the recommendation the best. So we tried to break it down with some diagrams such as this: the who, the when, the what. What does it consist of? Health education, yes, but also skill building and behavior modification and counseling. And those two the second and third items there, in large part, have been kind of outside the skill set of pediatricians. This is not something that we get trained for, as Dr. Kramer can tell you, in medical school. I think there is an improvement in the level of education that is happening, but there's not widespread training yet in obesity medicine or nutrition or physical activity guidance in medical schools, or even in most residency programs. So a lot remains to be done there, but skill building for the family also. And that skill building and behavior modification piece is where we need to pull in behavior change experts. And those could be, again, individuals outside the medical home. A few medical homes are privileged to have those type of individuals within the medical home, but not many, at least not many yet. The format, group or individual or both. The channel could be face-to-face. That's the strongest evidence, is face-to-face in person, but virtual is a potential. There's just not as much evidence yet for virtual intensive health, behavior, and lifestyle treatment. The dose I mentioned earlier, and again, a healthcare setting or a community setting with linkage to the medical home. Again, the focus is not that everything has to happen within the PCP office, because it can't in many cases. What linkages though can occur between primary care and community settings to enable this type of treatment to be available for kids and families. These are a few of the behavioral strategies that had the strongest evidence and that were endorsed by other national organizations that are pretty familiar to all of us. When it's not available is a big concern though. And we knew this would be a concern when the guidelines were published, because very few places across the country are able to deliver this type of intensive treatment. And part of our, we presented the available evidence, and the part what we hope to happen now is that this will be one of many things that will serve as an impetus to society, but specifically to healthcare, to insurers, to other sectors that have a stake in the health of kids and families, to be able to support more widespread availability of these more intensive treatment programs. So definitely delivering the best available treatment that you can, and building collaborations with others in your communities. And this could be a whole separate talk here, but I want to bring us back to this slide a little bit. Just take a look at that. And then I have a couple of different slides for us to just be thinking about. I know many others have thought about these issues as well, and there's more emerging research that is happening on these things. So, if we think about how to put the components together, how to put kind of what can each stakeholder bring to the table to help create a comprehensive program for youth and families. We know what the what should be. Based on the evidence, we know the dosage, we know the format, what the evidence supports for the format and the channel, and we know the where, and where these types of interventions could occur, that there is evidence for. And so what one option might be, again, it might not be the 26 hours, but what can you do in primary care? Maybe you can find a community setting that has some interest in partnering with you that provides physical activity opportunities for kids, or at least that you can refer to for that. Maybe you can also partner with another community-based setting that would be willing to partner with you to provide nutrition education, or access to healthier foods, or a fruit and vegetable prescription program, or a number of things. So there are a lot of different possibilities that I think will be further explored in the months and years to come. Another possibility might be, and the CDC is actually really promoting this starting to promote this right now. What about if you have a patient-centered medical home that has a staff person, such as a behavioral health professional or a registered dietitian, that can be trained or is qualified to deliver intensive health, behavior, and lifestyle treatment, and you partner with an established evidence-based program that has a curriculum, like what the CDC is now calling family healthy weight programs, and you bring that program into your clinic setting, and you partner and have after-hour sessions, or sessions that are convenient for families, even by telehealth. And then what if you have insurers that are willing to cover this treatment so that the family doesn't bear the burden of the cost of a more intensive treatment like this? Now, there is still going to be a family burden, because we know it takes time. And if it's face-to-face, it takes, you have to think about, your schedule, your gas to get there, your transportation, what are you going to do with your other kids, and so forth. So there is still a family burden, but how can these partnerships start emerging so that that families at least have more options for treatment? So I want to, because again, we're limited on time, I could talk about this all day, and this is an area of great interest to us at the center, but I will move on to continue so that we can get to any questions that people have. The pharmacotherapy recommendation if you can imagine, we're working on these recommendations, and at the same time, emerging evidence is happening. So there's a continuous evidence review that is happening while we're writing this guideline. And one of them, one of the evidence areas that was emerging was pharmacotherapy for kids, and wanting to feeling that we should include, again, based on evidence review, an action statement about pharmacotherapy. So we did include one, again, based on the best available evidence that adolescents with obesity can be offered weight loss pharmacotherapy, of course, according to the indications, the risks, and the benefits as an adjunct, as an add-on to intensive health behavior and lifestyle treatment. So the foundation is still intensive health behavior and lifestyle treatment, but for some kids with severe obesity, especially, they may need additional support. So that is a pharmacotherapy recommendation. And then there's a surgery recommendation because, again, there is evidence to support it. And there's longer term evidence to support it in surgery, even than for pharmacotherapy. The pharmacotherapy in adults has been happening for a number of years, but for adolescents, the evidence is it's newer, but it's still there. And versus surgery, there's several, over 10 years of experience in these well-designed, comprehensive types of surgical programs. So the recommendation is not for surgery directly. The recommendation is that kids that have severe obesity that are 13 and older would be sent, referred for evaluation to a place that can do a very thorough job. So, we feel strongly that kids need to be treated and teens need to be treated by experts in pediatric and adolescent care. And there are centers across the country that are actually centers of excellence for providing comprehensive evaluation and surgical treatment of adolescents with severe obesity. So the recommendation is that they should be offered referral. It doesn't mean that they're going to have surgery, but that they should be offered that option, again, as one option for treatment. So putting it all together, there are a couple of other tools, and I'm going to give you a website here at the end where anybody that's interested that wants to look at the guideline itself or the executive summary or any of the implementation tools that have been developed so far, there's a one-stop shop for that, and the access is free to those. So we had a table that kind of specifically for the PCP, what are your roles? What do we want to see PCPs be equipped and feel comfortable doing? And again, another diagram that just shows, if we think about the medical home, literally a home, what is the foundation? It's an ongoing assessment of those risk factors and evaluation of the whole child and use of motivational interviewing for shared decision making and ongoing counseling and referral to a more intensive health behavior and lifestyle treatment program. That's the foundation of the house. And then you may need to add additional more advanced treatments as needed, depending again on the child and family, the seriousness of the child's conditions and the family's willingness and desire to have more advanced treatment. We couldn't leave out advocacy because, again, we know that this is a very important aspect of having this actualized. So it's one thing to have all the evidence together and make recommendations. It's another for it to actually be able to happen so that kids and families can have better access to evidence-based treatment. So we made a number of recommendations for different sectors, including healthcare, and again, promoting partnerships and better coverage. That's key because, again, these programs have to be covered and able in order for them to be accessible to families. Clinical decision support systems mean what we do within and outside the electronic medical record to help us better care for these kids in an evidence-based way. Better education, I've already alluded to that. As well, and accelerating progress for policy change, not just legislation, but other types of policy changes as well within and beyond the healthcare sector, and then targeted policies to purposefully address structural racism that drives the disparities that we see. There are a number of different resources that have been developed and that are being developed. This is just one example. It's kind of the what should pediatric healthcare professionals do and how. So this is more of an overview. The clinical flow diagrams actually get into the how. This one is on assessment and evaluation, and then there's one on treatment. Suggested treatment approaches and how to intensify treatment, and the different options and support on interpreting lab. So a number of different things, again, are available, and more will be coming, especially again, kind of focused on pediatric healthcare providers. There's also patient and family resources. So there's updated content on the AAP's parent-facing website called healthychildren.org. And this is the website I was mentioning. So if anybody wants more information, I will say I cannot share my slides. I'm not allowed to do that because the AAP is not allowing us to share our slides, but I can share the website. So the website has a lot of different tools for individuals who are interested to look at, including multimedia assets, 2 or 3 minute videos, podcasts, blogs. There are a number of different things that are available to help promote the spread of the clinical practice guideline. I wanted to close with a great quote from our parent, Doug, who was our parent representative for the development. He was so faithful about giving input, reading everything, giving suggestions about how the guideline could be improved. So I think it's a good way to end the talk here. And I think we may have just a few minutes for questions. So thanks.
Thank you, Sarah. That was outstanding and excellent information, and nice job keeping us on schedule with that. So with that, I would like to open it up for questions. I will make a quick note for those that are online. We'll need to repeat the question so they can hear it, because they can't hear what's in the room. And feel free to just raise your hand, and Natalie is going to be monitoring the chat for us. Yeah, if you're in the room, we're going to use this mic so everybody can hear it a little bit better, and make sure Dr. Hampel can communicate it to our online people, and then let us know if anybody online would either like to speak or has a question. So, Robert.
Well, I've got a comment and I guess, I don't know if it's a question, but maybe just something for you to expand upon. First, the comment, I think it is a huge deal that you were asked to be the lead author of these very important recommendations. I think it speaks a lot about your expertise and the opinion of your colleagues to give you this important role. And I think that we should all be very proud that, one of our own has been tasked with such an important charge. So congratulations to you, and great job. This is all just amazing. But my comment, I guess, is I haven't paid too close attention to it, but it does seem that you've been getting a lot of press about this. I see you're in the Wall Street Journal and New York Times and Washington Post every single week. And I am curious as to what that interest has been like. Are people just curious about it? I have seen some, as with everything, there seems to be incredible misunderstanding by people who clearly haven't read the recommendations. The one comment I received from someone is, oh my gosh, we're putting kids on medications and giving them surgery, which is clearly, as you articulated, not the case. So I guess, can you comment on how this has been received so far, and the scopes and limitations of what these recommendations are? And then just the final thing was, you mentioned at the beginning that this is a part of a collection of resources. So you mentioned this is treatment, and there are other things that are going to be coming out around prevention or have come out, things like that. So if you could just talk about maybe those things.
Sure. So should I repeat that? So several different parts. One is kind of what has been kind of media national reaction to this. So I'll take that one first. So you're right. What's happened really is that, you know, the previous recommendations did not include much about pharmacotherapy because there wasn't anything to really say back in 2007. And I'm not even sure if there was much of a mention of surgery. There probably was. But since then, again, the evidence has really exploded. And because those are new and just inherently kind of controversial, especially for whether or not people acknowledge it, there is weight bias and stigma across our society. And there are still many individuals that think, well, you ought to just be able to eat more healthy and exercise more, and that should take care of this problem. Why should we put children on medication or offer them surgery for this? This is not just a lifestyle problem. And that's part of what we have tried to get the word out about. This is a complex issue. It is a complex interplay. More kids than ever have genetic predisposition, and then added on to these environmental and social risk factors. This is not just a lifestyle issue, but because there is such widespread bias about that, I think that's driven a lot of the like sensationalism about, well, here you're offering medication or surgery. And, you know, as several of my colleagues have said, if a child had cancer, we wouldn't be denying them treatment. We wouldn't be denying them the most, you know, evidence-based and the up and coming treatments. If a child had asthma, you would treat them right away. If they're, you know, if they're sick, you're going to be treating them. So we cannot continue this widespread bias about what treatment should and shouldn't be offered. I think another thing that's played into it is, again, it's new. Pharmacotherapy is new. Surgery is not new, but in fact, the AAP had a policy statement about it back in 2019. But it's still new in minds of many that are, you know, in the public. And it's going to, as a reporter, I can say I have a whole new appreciation for the term investigative reporter. I'm like, oh my goodness, I need a vacation about now. You know, because it's going to get the headline is going to be catchy and drive attention. I think that's what's driven a lot of it. We've thankfully had really good support from the AAP Media Relations and our own Media Relations department at Children's Mercy to help with that. And we have a whole lot of writing committee members. So thankfully, not all the requests go to me. We're able to kind of divide and conquer those. So I hope that may answer one. And then you had a question about what other implementation or maybe what else is the suite of resources. So as we know, obesity is not just treatment. It's not just prevention. There's a whole lot of, it's a continuum of condition and illness and preventable to some degree. And so, and of course, the other thing that's gotten a lot of media attention that pulls into what is coming out from the AAP is that the concern about raising risk of disordered eating. So that has been big in the media and, you know, again, very, quite honestly, hurtful to those of us who really worked hard on the guideline and care very deeply about kids with obesity. We love these kids. We love working with them. We know that there is a higher risk for kids with obesity to have disordered eating. And so, you know, we spent as much attention in the CPG as we felt we could on it, but there are those that don't think we went as far as we should have. And so we are actually partnering, AAP is partnering with the National Eating Disorder Association and the Academy for Eating Disorders, which is more of the research arm of NEDA, to create better resources for screening in primary care and in specialty settings for disordered eating, and a better procedure for how to screen. Now, there's already an AAP statement on this, prevention of eating disorders and obesity that exists, that was published in 2016. Just so happened that it was up for renewal. So it's being revised, and it's being revised in partnership with those national organizations. And I don't know, but I would expect it's going to come out either later this year or early next year. So there's going to be more guidance from the AAP about how to effectively screen and rescreen and what to do if you detect a child has disordered eating patterns in primary care. So there's some good coming out of that. And I'm really, you know, thankful for that. So that's one of the resources. There's also this prevention resource the prevention policy statement that's been developed by the AAP section on obesity. And that's going to be coming out probably later this year as well. And we're looking again for how can we, kind of integrate all these different sources. But again, we're very interested in it's one thing to have it on paper or in print. It's another to how to actualize it in the primary care office and how to partner, how the boots on the ground part, how to actually implement partnership with community organizations to help promote, better opportunities for kids. So that was part. And then was there another one, Robin?
I think you got it all.
Okay.
Yeah. Did a great job.
We want everyone online to know how great we think you are. So
Oh, well,
Yeah.
thank you.
Yeah.
I appreciate that a lot.
what other questions do you have for Sarah? Sarah, I know you alluded to some of this, but one question I have, stop sharing this for just a second. And maybe you can speak a little bit more to this now, is about reimbursement. So we know that we have the guidelines, but it's difficult to make these things happen if primary care providers or others are not being reimbursed for this level of treatment. Can you speak to that for just a little bit?
Yes. So Shelley's question had to do with how, what are the next steps in terms of advocating for better reimbursement for treatment, all the way from more frequent primary care provider visits to coverage for these other treatment options like intensive health, behavior and lifestyle treatment, pharmacotherapy, surgery, because there are coverage gaps in all these areas. So I don't have a good answer other than to say that that there's strong interest in this. Their AAP has a whole separate entity that is within themselves called Institute for Healthy Childhood Weight, and they also partner with policy advocates at the AAP. And so there's and other organizations like Children's Hospital Association. So I think there's going to be more to come on this issue, but it clearly cannot happen without better coverage. And in Missouri, I'll just put a quick plug in. There is now a Missouri Medicaid benefit that covers intensive health, behavior, and lifestyle treatment for kids and adults with obesity. So that benefit covers for kids, nearly 30 hours of intensive health, behavior, and lifestyle treatment in individual and group settings, and covers medical nutrition therapy as well. Other insurers, we really want to follow Missouri Medicaid's lead in our state and in the state of Kansas, certainly, and nationally. There's other states that are more active, becoming more active in this area. And we spent about 10 years getting the Missouri Medicaid benefit to actually come to fruition. And we don't want other individuals that are interested in this in other states to be able to, we want to share the lessons learned because 10 years is a long time, and we are very grateful for the partnership and are continuing to work with Mo Health Net. But there are certain lessons I think we've learned that we can that we would like to share with others.
Yeah. Okay, well, I know we're at our time boundary, so it's just a little bit after 11. I do want you all to join me in some active applause for Dr. Hampel and her. Thank you so much for taking the time to share this with us. It's great information and also demonstrates the importance of the type of work that we're doing here, that we can't just rely on, as Dr. Hampel just shared, this is a environmental issue as well. And so we're all really connected in the systems in which we learn, live, work, play, pray, etc. And the work you're doing is important, and making these connections and collaborating is really a key to improving health broadly. So with that, thanks for joining us today. You can see the evaluation QR code on the screen. Please take a few minutes and give us feedback. It will take you literally 2 minutes, unless you're giving us great ideas for what other topics to have at future meetings. Again, thank you so much. We look forward to seeing you at other sector meetings, and our next quarterly meeting will be held in June. We hope to have that date secured soon. Thank you. Great to see you all in person.